Welcome back, everybody. David here again with Med School Boot Camp. So in this video, we're going to talk about glucose clearance. And this is a continuation of what we talked about in the previous video with renal clearance. So if you haven't seen that video, go ahead and check that one out real quick. So as we talked about in that previous video, glucose clearance is an example of when C, or the clearance of a molecule, is actually less than the GFR. So the GFR is essentially what is filtered at the Bowman's capsule into the tubule, but glucose is actually reabsorbed. And so the clearance, the amount that actually leaves the body, is going to be less than is actually filtered. And this has to do with the fact that in a normal, healthy, functioning individual, between ranges of 60 to 120 milligrams per deciliter, approximately 100% of the glucose is reabsorbed in the proximal convoluted tubule at the SGLT2 transporter, also known as the sodium glucose co-transporter, which I'm highlighting here. And this is important, right? Because we use glucose for a ton of reactions in our body. We don't want glucose to actually leave the body. So although it might get filtered at Bowman's capsule, when it comes through, it's actually reabsorbed in the proximal convoluted tubule. So if we think about it, glucose is very important to the body. We use it as one of our primary sources of energy. So it's important that whatever glucose is actually filtered in Bowman's capsule gets reabsorbed by these SGLT2 co-transporters, because we need that in the body. We don't want it to actually be filtered all the way through the nephron and leave in the urine, because we want it in the body, again, at these normal physiologic ranges. Now, I want to draw your attention to our graph. And you can see that on the y-axis, we have the glucose transporter, which is in units of milligrams per minute. And on the x-axis, we have the plasma glucose, which is approximately 60 to 120 milligrams per deciliter in a normal, healthy individual. Now, if we look at our lines I've drawn here, we can see that essentially, in theory, right, filtered glucose can go on indefinitely. Now, in reality, the filtrated amount is not able to go up indefinitely. And the reason is because there's a principle or a value at which we can't bring the glucose molecules across at a faster rate. These transporters can actually get saturated. We can only bring so much glucose across at once, and the value at which this happens is called T of M. And the T of M is the rate at which the transporters are saturated. We can't bring back more glucose. Now, on the graph, we also see our excreted value, which looks somewhat like this. Remember, the excreted value talked about in previous videos includes what is filtered, the GFR, in addition to what is actually secreted into the tubules itself. So some gets filtered here, plus some is actually secreted by other transporters as well. All of that actually leaves the body together is termed the excreted amount. Now, there's a really important concept here known as the renal threshold, right? We said at some point, these are actually saturated. We can't bring back more glucose because we don't have enough activity or enough transporters. And this is usually around 200 or so, where we start to see more glucose being present in the urine because, again, the transporters are saturated. The T of M has been reached. And so that is to say, in our abnormal findings, at approximately 200 milligrams per deciliter, we start to see glucosuria, or glucose in the urine. Why do we see that? Because we've reached the renal threshold. We're unable to bring back all of the glucose that's actually being filtered at the kidney itself. So think about this like a factory line. So let's say we send this person in the assembly line 100 blueberries, and they're able to take out 5 of those blueberries before it moves on to the next person. Now, let's say we send them 200 blueberries, and now they're able to take out 10 of the blueberries before it moves on to the next person. However, if we then send this person 300 blueberries, they're unable to take out 15 of the blueberries. 10 was their max. That's as many as they could remove from the pile of blueberries before it got past them and it moved on to the next person for packaging. And so 10 was their max. We reached the maximum amount that can actually be removed. And thus some of the bad blueberries are going to make its way through. Or referring to our example here, some of the glucose is going to make its way through because it's unable to be picked out. It's unable to be reabsorbed into the body itself. And this is going to present as glucosuria. And so again, this area at which we limit the ability to bring back more glucose is known as the T of M, or when we have saturated all the receptors. Next, we'll look at our term reabsorption. And you can see on the graph that reabsorption is increasing, and then it kind of plateaus at a certain value of glucose transport. And again, this gets back to our example in that we're able to reabsorb the glucose, right, through these transporters, through these receptors. But at some point, the reabsorption process where we're taking stuff out of the tubule and bringing it back into the body, it gets saturated. We can't bring back more glucose. And that's what we see here, is that we get this plateau. We reach an amount in milligrams per minute that we can't bring back more glucose. If we can't bring back more glucose, what's going to happen? Well, it's going to continually make its way through the tubule and be excreted in the kidney itself. Now, interesting point here is that we have increased filtration in pregnancy, which ultimately leads to increased GFR. And so that is to say that in pregnancy, we have an increased GFR. We have an increased filtration of all solutes. And that means our renal threshold can actually get shifted over to the left. And this is important because this means that we can actually see glucosuria in pregnancy, despite the fact that we have a normal plasma concentration of glucose. Why is that? Because the threshold is lower. The threshold has been met because there's so much extra stuff being filtered. And thus in pregnancy, it can actually be a normal finding to see glucose in the urine versus the non-pregnant patient. This is pretty much always an abnormal finding. So we say that in pregnancy, it's normal to have glucosuria, or glucose in the urine, in the setting of normal serum glucose levels. And the final thing that we need to talk about in this video is the idea of the splay phenomenon. And the splay phenomenon, which you'll see kind of on this region here on the graph, is essentially due to the fact that there is a heterogeneity of nephrons within the kidney itself. There are different TM points, or there are different rates at which glucose transporters are fully saturated depending on the nephron within the kidney. So that is to say that not all nephrons are the same. So let's say this nephron is saturated at 350 milligrams per minute, and that's representing this nephron over here. So we're saying this is our 350 nephron. But there could be another nephron that's located approximately next to it where its saturation is actually at 300. And so you can see here, right, this nephron, the SGLT transporter, is actually saturated at 350, but another one next to it is actually at 300. So there's a heterogeneity between the nephrons. And this is important because this explains the splay phenomenon. Instead of the graph kind of coming up here and having a very sharp angle, you can see it's kind of a rounded appearance, which is due to the fact that the saturation of glucose is reached gradually rather than at a sharp cutoff. It's not exactly when you get to 350, it's cut off, you can't get any more. It's that it's somewhere between the 300 to 375 range, depending on the heterogeneity of different nephrons throughout the kidney, that leads to kind of this curvature or splay phenomenon. So as far as the test question goes for this content, it's really going to be a little bit more of a conceptual question. I can see them asking you a question about the splay phenomenon and giving you more long stem answer choices that actually explain what's going on here, dealing with the heterogeneity of the nephrons. They can also ask you questions about why is it normal that glucosuria is present in pregnancy, and the idea is the fact that we have an increased GFR, causing more filtration of all the solutes, decreasing our ability to bring back all the glucose. This can be a normal physiologic finding as well. So keep this in mind here. They really want you to understand the physiology of the SGL2 transporters, bringing back the sodium and the glucose. In the future videos, we're going to talk about certain medications called SGL2 inhibitors that can actually inhibit this transporter. It brings back less glucose into the body. And what kind of patients might benefit from this? That's right, patients who have diabetes and they have too much blood sugar, and we actually do want to excrete some from the body. So quick summary of this video: glucose clearance, building on our previous video of renal clearance. Normal range of serum glucose is between 60 and 120. Almost 100% of glucose is reabsorbed in the PCT. Why? Because it's our primary energy source. There are a couple states, such as pregnancy, where seeing glucose in the urine is a little bit more reasonable and expected, and this is due to the increased GFR. Some of the abnormal things we need to know is that glucosuria begins at approximately 200 milligrams per deciliter of plasma glucose, and or at the rate at which glucose transporters are fully saturated. This is dependent on the nephron itself. They're not all the same. So some might be saturated at 350 milligrams per minute, whereas others might be saturated at 300. Some might be 375 or 400. You get the idea here, but this explains something called our splay phenomenon, where we don't see a sharp cutoff in the amount reabsorbed. It's more of a rounded picture because not all of the transporters and not all the nephrons are saturated at once.